Today on Home Care Heroes, we feature an agency owner who's also a nurse and a case manager for one of the Medicaid MCOs. Her talk today is about how to comply with your documentation for Medicaid, and there's a lot we could learn from this. Enjoy.
Welcome to the Home Care Heroes podcast, featuring trending topics and practical wisdom for success in home care. Here's your host, Ken Accardi.
Podcast. I have Temperance Bruder is our special guest today, and Temperance comes from the great Commonwealth of Virginia. I think I shouldn't say the state of Virginia, I should say the Commonwealth. I'm not exactly sure what that means, but I live in the Commonwealth of Massachusetts, so I guess there's something to it. And so Temperance is really a home care expert. She's been in a whole bunch of aspects, whether that be working in the home health side. She's done hospice work. She's done non-medical home care work, and she's even worked with some of the MCOs and all those types of things. And today's subject is really going to be how to get your documentation right on the Medicaid side, which is really, really important and really crucial, and something that we really haven't covered deeply on the show. So I'm very excited. And let me start by saying welcome, Temperance.
Well, thank you. I appreciate it.
All right. Well, it's great to have you here today. So I kind of gave that brief introduction, but tell us a little bit more about your story. I mean, how did you get here in what's been your home care journey?
Well, so I began as an aide myself about 15 years ago. So I have done every aspect in the field of home care. I started again as an aide, grew to a staffing coordinator where I planned scheduling, dealt with staffing and clientele. And then I became office manager, worked a couple agencies at the same time, went from office manager to payroll and billing. And then I just decided last year when my mom had her issues that after her passing, I was going to go ahead and open up my own agency since my mom begged me so much before she passed. And so here I am today with Touch of Eden. But not only do I own my own home care, but I am also a home care consultant.
Fantastic. And I will share that Temperance has done some consulting with some of our other ANCODA customers in Virginia, and they've all been really, really good at their compliance and all that kind of thing. So that is great. Okay, so let's jump into our topic. And I guess, the first thing I think of, here, and we said that our topic is going to be getting your documentation right, is, what does that mean? What are the most crucial documents that folks need to attend to with their home care and make sure that they do have right and well documented?
Well, Ken, a lot of people confuse. So when they become agency owners, we have to go through an initial inspection. So with that, we have to do the policies and procedures to be able to own our agencies. But a lot of people don't understand that when we become agency owners and to be able to work with Medicaid, we also have to comply with Medicaid documentation compliance as well. So in order to do that, we have to comply with their documentation requirements. So in order to do so, we have to be able to comply with 97s and 99s, and part of their requirements are also 98Rs. All of these numbers are confusing to all of us, but we have to know them. So a lot of the issue with being a consultant is that I give the overview of what these numbers mean, break it down, and then explain the documentation.
Okay, so let me stop you there. So let's talk about, what is a 97, a 98, and a 99, and let's kind of put them in terms that everybody in all 50 states can understand.
Sure. So a 97A and B, basically for DMAS medication, for DMAS documentation is a plan of care. So this is how we derive how many hours a week a member can get. A member/client, they can be synonymous. So a plan of care is basically 97A and B, can also be used for personal care and respite, okay? So this is what the nurse or the LPN reviews, but only a nurse can do this in the state of Virginia. I'm not sure how it goes nationwide, but in the state of Virginia, a nurse does this documentation. But we use the composite score down on the bottom, and this is how we come up and create the amount of hours per week. We count the ADLs, or the activities of daily living, bathing, dressing, transferring, eating, and all that good business. And then we do medication, and down on the bottom, it's cooking, cleaning, bed making, and the other needs like doctor's visits and things of that sort, or IADLs. So all of these tasks align and create the weekly units that we need for the plan of care. Now, the 99 is the nursing assessment. For the initial assessment, this needs to be done in the state of Virginia by a nurse. After that, they can be done by an LPN. So this is how we truly do the level of care, and we compare this with the Universal Assessment Instrument, or the UAI, which is conducted by a social worker and a nurse upon initial intake to the EDCD waiver. And so these two documents help us get this member their hours per week to be able to get them into the Medicaid program.
Perfect. Okay, so again, just like putting it in generic terms, we have a plan of care. This is what we're going to help the individual with. We talked about activities of daily living, instrumental activities of daily living, and we also talked about doing some scoring based on their ability to care for themselves independently, let's say, and that helps us determine how much care they need and all that type of thing. And then we move on to the nursing assessment, which in Virginia is called the DMAS 99. And that's where we kind of go, is that more like an assessment? We go through the body functions and, it's a little bit more medical. And like you said, it initially has to be done by a registered nurse, but then it can be done by an LPN thereafter. Okay. And I think you also mentioned something called the DMAS 98. What was that one all about?
So the DMAS 98R, basically, this is where we paint a picture of what the member looks like. A rollator, a walker, a cane, how they move, how they dress themselves, what kind of bathing assistance, if they need a human health aid assistance, supervision assistance, what kind of care that they need. And this is where we put a picture to our MCOs explaining why we are requesting the amount of hours that we are requesting on the plan of care or the 97 A and B. So this needs to be congruent to the 99.
Okay. Perfect. I'm taking some notes here. So I think we have used a couple of acronyms that not everybody might know or not know. So let me cover some of them. So one is DMAS. So in the state of Virginia, correct me if I'm wrong, but I think it stands for the Department of Medical Assistance Services.
Correct.
Is DMAS. So that's essentially the part of Virginia Medicaid that is, kind of working on the whole question of authorizing care and complying with care and those types of things. Then you also mentioned MCOs. So in some, many states, there's like this state Medicaid department. So like in Georgia, we deal with GAMIS, the Georgia Medicaid Management Information System. And in Missouri, we deal with EMOMed, the electronic Missouri Medicaid, and so on and so forth. In Kentucky, KIMIS, the Kentucky that kind of thing. But in Virginia, they've actually done what a lot of other states have done, is they've said, we're going to outsource the management of the claim handling and things like that to what they call MCOs, or Managed Care Organizations. Right. And those are generally run by insurance companies. So you'll see names like in Virginia, it's going to be Aetna, Virginia Premier, Anthem, Optima. Sometimes in other states, you'll see Molina, you'll see Meridian, so it's all the Blue Cross Blue Shield. So you'll see all these different insurance company names, and they're in the business of administering claims for healthcare. And so some states, as I've said, have decided to outsource their Medicaid claim management to these managed care organizations. So that clarifies a few of the acronym soup here and that type of thing. And then you've painted a really nice picture of how the DMAS 97, the DMAS 98, the DMAS 99 all play together. And I guess I put a nice name on the DMAS 97 as the plan of care. That's a good generic name. On the DMAS 99, we called it the nursing assessment. And what would you call a common name for the DMAS 98?
So the DMAS 98, we here in Virginia call that the KeyPro assessment.
Okay.
Basically, you can just call that the picture assessment,
Okay.
where we just basically describe in detail how we have our member, what our member looks like. It's the best way to explain in detail what our member needs and how our member needs that assistance from our staff.
Okay, perfect. All right, I have a question, and this is one that has always baffled me a little bit. I've always been under the impression that when one of our agencies gets an authorization, that the first thing that they're getting is, okay, you're authorized to care for this person for 20 hours a week, and then go, right? And then it sounds like at that point, of course, they have to have their nurse do these different assessments and the picture and the nursing assessment and the plan of care. But I mean, it sounds a little bit like a chicken and the egg thing. Am I right that they're first being told it's 20 hours a week because that came maybe from that universal document done by the social worker? I guess how does, is it, I guess I didn't realize that the agency itself had a say in how many hours of care the person should get. And if you could clarify that, it would be amazing.
So the universal assessment, or the UAI, just determines by the social worker and the nurse when they originally go out, it determines how the patient looks. And so each agency, when they send their nurse out for the initial assessment, breaks down in the agency's discretion how much time they think that this member needs. And that's why the plan of care is there, because they will determine how many hours they feel that member needs. And then they have to use that composite score on the bottom to rate that member to get the amount of hours per week.
Okay. So I guess just sequencing it a little bit. I mean, does the agency first get a request for a DMAS 97 to be done, or do they get that authorization before they even start?
So what it is that the agency has to go and initially assess the member. Then they come back to the office, they do all their data information, and then they have to submit up to the MCO. When they submit up their authorization request, the insurance company has to make the decision whether or not they agree to that amount of hours requested. If they agree, they authorize it and they will retro it back payment-wise. So they will give you that amount of hours. If they don't, the medical director and utilization management will say, no, we don't agree. There's not enough medical necessity. We're going to erase some of the hours. We'll give you XYZ. And so then you have to take it down.
Okay, perfect.
Yeah, that's where respite comes in.
Okay, got it. And so why don't you explain that a little bit more? And it's not the same in every state, although we definitely see like personal care and respite in Missouri. We see definitely personal care and respite in Virginia. But do they, so how does it work in Virginia where that they say that those respite hours might come in?
So here's the big issue with respite. Respite is one of those things that is for the primary caregiver who is non-paid. So this is the person who takes care of this member and they don't get payment for them at all. So this could be the spouse, this could be the mom, this could be the child. Okay. So what it is that they have to request from the agency. Hey, I need to go to the doctor's office. I need 4 extra hours said day. Can you send someone to my home and watch them for said extra hours? The agency is required to document this, and then they can go ahead and take care of that. So it is only respite approved if they have a non-paid caregiver. If they do not, respite's not authorized. But respite is fiscally approved July 1 to June 30. Okay, 480 hours a year.
Got it. Okay. If you get it, you get the 480 hours a year max, and it's from the July 1 through June 30. Perfect. All right. Well, I'm really glad that you mentioned that, a lot of times we see authorizations for a year, in this case, very specifically July 1 through June 30. But, whenever the person comes on the program, we generally are going to see their personal care authorization is going to cover this 1 year period. So does that mean that the agency should, they do that upfront assessment, they get it all right, and then they don't have to check it again for the entire year?
No, because there is a misconception with that as well. Some insurance companies will give a year's authorization. Some insurance companies give 6 months. And the reason for that is that they want to make sure that the level of care is true to care. It is very vital that you maintain visualization on your client. 90-day assessments are minimum for your 99 or your nursing assessment. You need to make sure that your nursing staff are out there and maintaining visualization. You need to make sure that your office staff are calling and verifying your members are taken care of, receiving their staffing that they're required to receive, but a 90-day minimum. So you should have 2 nursing assessments every 6 months.
Okay, perfect. So, okay, great. And then as sometimes the person might be getting home care because they're overcoming an injury, they might be getting better. Sometimes they're just elderly, they might be getting worse. So what are, as somebody who's done a lot of these yourself, when you're going and redoing that, let's say DMAS 97AB plan of care, what are you trying to ascertain on that? Let's say, you've gone 80 days later after you started their care, and now you're checking them out. What are some of those, things that you're looking for to see if they've, gotten better, gotten worse, and how to reassess that?
So a lot of people are under the misconception, plans of care usually tend to last only 1 year. So it's always vital to remember plans of care need to be redone yearly. But if there is a change in care, again, true to care for that member, if there is a need to increase that level of care for that member, that plan of care needs to change to an increase in hours. We need to go ahead and up that member's hours. But everybody needs to understand Medicaid has a hard stop for home care at 56 hours a week. If there is a requirement for 56 hours or more, there needs to be a request for supervision or a medical doctor's necessity reason.
Okay, got it. Okay, so perfect. So we might get that person in there, and maybe they first came in. Let's take the case where they had some medical hospitalization or something. So we have them maybe at 48 hours a week or something like that, and then we come back and we're like, wow, this person's really recovered well. And then we go back 90 days later and we're like, hey, I think we could get back to 32 hours a week, and so on and so forth. And then in other cases, you might see that it's the opposite. But I think the really crucial point here is that, you really can't be thinking of this as that entire 6 months of the authorization or that entire year. You have to be on top of this and reassessing and planning that. And, one thing, and again, we don't really talk on this podcast so much about, what we do at ANCODA with our software, but given that we do work with a lot of the agencies in Virginia, we set it up so when you do fill out that DMAS 97AB, that it's going to take all those tasks that in Virginia, there's 25 types of tasks that are asked of people. And then there's 4 questions that are asked because Virginia has a really good best practice, which is, if there's a change in the person's condition, they always want that to be escalated to nursing staff. And that might, kind of trigger who you should be doing those assessments more frequently than 90 days, when you do see that, change in that. But anyway, the point I was going to make is that when you fill out that DMAS 97 in the ANCODA system, it's actually going to populate your caregiver's task list, that plan of care, to make sure that they always match. And when an auditor comes in, they're going to want to make sure that they match. It's like, so if you're in a situation where it's like, okay, I brought on this client, I generically chose some tasks for the caregiver to work on every day, and then you get a DMAS 97 that doesn't match that, that's where you're going to get into a little bit of hot water. So if you do kind of follow the flow of, okay, we did the assessment, it created the caregiver's task list, and they 100% match, and then you do the reassessment, and if they need more help or less help, that corresponds, that's a really good best practice as well. So this is great, and I think people are really going to appreciate this. So thank you, Temperance. This is going great. Let me kind of shift in another direction. I mean, we've been talking a lot about documentation, but something else that maybe goes in hand with this is also education of your staff. So I'm kind of wondering, I kind of feel like some agencies are like, all right, well, I educated them when I onboarded them, or yeah, I'm going to do like an in-service every year or something like that. It sounds like, just based on what's going on in the world and the kinds of changes that we've seen, that frequency might not be good enough. And maybe you could tell us a little bit more about your thoughts on education and how frequently to do those in-services and keep your staff up to speed.
So, okay, education is an ongoing thing, and we understand that change happens. I mean, look, for the last 2 years, we guys, we've been hunkered down. We've had a pandemic. Things have changed. We were stuck home for a long time, and our caregivers were the only ones, in the homes. But even that's changed. DMAS has kind of given us where we can do quarterly trainings. And so it's necessary not just to do the paper packets. We have all of these companies that we can do online in services once a month. But it's vital to have our staff know office management, to know the leaders of our home care agencies and know who our faces are. And it's vital that we know who our staff are, so that way we can promote within the agency and we can tell them, you know what, thank you, because it is our staff that make our home care agencies what they are today. So it's vital quarterly at a minimum to meet our staff face to face and say, you know what, great job, thank you, we appreciate you. Have face to face conversations with our staff. Learn COVID, learn new things. Our staff could teach management things every day. So go out there, learn from them, teach them a few things. There's always ways to learn new things, always ways. So don't stop learning.
Yeah, fantastic. So, I would say if you look across all the episodes we've done in Home Care Heroes, and I think we've done at least 25 or so episodes, that there's probably not been one yet that covers the most important defining challenge of our industry today, which is really recruiting and retaining great caregivers. And I think that we've heard from HR specialists and recruiting specialists and website specialists and search engine optimization specialists and all these different folks. But now here we are, and we're talking to a Medicaid compliance expert. And the great advice here is, it wasn't, Temperance could have talked to us more about, okay, like DMAS is going to give you this education on COVID and that. And she certainly mentioned that. But, the most important thing that you brought up is that it's an opportunity to see them face to face, learn from them, see what their challenges are. And also, kind of thank them for what they're doing and take the opportunity to learn from them and let them teach one another. And that, it's kind of hard in home care. We're a little bit, we don't have that, we're all in the office every day talking to one another and having that level of support and camaraderie. So if you are able to, do these at least quarterly, that's fantastic. And you use some words, you said, DMAS allows us to do them monthly. And is that something that's like reimbursed, or what do you mean it's like allowed to be done monthly?
Okay, DMAS gives us the ability to mandate them.
Okay.
So 1 hour paid training quarterly. We have the ability to do these in services. We send them, there's a lot of downtime with home care. So we send them with our in services, paper packets, whatever. We send them with them. They can do them while they're doing, service with our clients. With them having a lot of downtime, our clients might take a nap so they can read their packets, stay busy while they're waiting for their client to, rouse back around. With us having the ability to do mandated, quarterly trainings, we can teach them the new, DMAS sends out, COVID trainings or updates for us office management, for us to stay on top of our P's and Q's, for us to learn new things within our genre of staff, but we can take back and teach them what we've learned. They can teach us what they've learned. But hand in hand, the one thing that I have learned being staff myself in home care field, as well as being in the office, it's never too late to be humble, because when your staff know that you're humble, you're willing to do a pop-up and go and see your client. When you're willing to, lower your standards and understand it's the small folks that make big folks big. Learn and remember where you came from. We have to take care of our community, and we have to be out there, and we have to appreciate where we came from. And so not only take time to reteach our staff, but go out there and let our community reteach us. So go out there and go see our staff in the home with our clients and praise them in front of our clients. Thank you for doing such a great job with Mr. Smith today.
Yeah, fantastic. I love that, and very uplifting. And I think it's a great way to handle that. Okay, so I guess, just one other thing that comes to mind a little bit is, now that we're pretty much all electronic and that kind of thing, I mean, is it just that, as long as I have my current paperwork for what's going on today, maybe it's in the computer, is that good enough, or what best practices do you have in that arena?
So I'm old school. Even though I'm young, I'm old school. So, we have the ability to have HIPAA cloud. We can put everything electronically and have, the ability to work from home one day. We've all learned this during this pandemic. Best practice, though, is to have paper documentation, because if you don't want certain entities that be within your computer documentation and looking at everything, because if you allow them to look, they're gonna look. So if you hand them a binder and say, here you go, you can look at said article, they're gonna only look at said article. Best practice is to have paper documentation, and HIPAA compliance, hold it for 7 years.
HIPAA compliance, right?
HIPAA compliance. Just make sure you have it in a locked file cabinet, hold it for 7 years, and just make sure that you have your documentation in tow. Not only will you have it in compliance on paper documentation, but you can have that in case there needs to be a paper trail sent to somewhere else, because these clients are allowed to ask for any documentation that you've obtained while you've cared for them.
Perfect. All right, very good. All right, so I think this is probably a really good breaking point for us for today. I think that our folks are going to digest this and they've learned a lot from it. But let's cover again how folks could get in touch with you. I have some of that information here. So again, your name is Temperance Bruder. I'm going to spell that for you. It's TEMPERANCE, Bruder, BRUDER. And your agency is actually called Touch of Eden Home Health. But through Touch of Eden and reaching you, they could actually, not only work with your agency for care, but they could also engage you as a consultant. Is that correct?
Correct. That is correct.
Okay, great. And so let me give some contact information. So the email is going to be a big long one. It's going to be Touch of Eden Home Health LLC @gmail.com. So I'll say that one more time. Touch of Eden, EDEN. Home Health LLC @gmail.com. And a great number to reach Temperance would be 804-286-9176. And do I remember, Temperance, do you speak both English and Spanish?
Eso es correcto. That is
okay, perfect. So that's great. So if you are serving, Latinx community as well, and that kind of thing. So we have Temperance speaking both languages. And and if you could just, again, summarize on the consulting side, because we haven't talked about that as much. What are some of the things that you can consult, whether it be a new agency or maybe an agency trying to get to the next level? What are some of the things you could help them with?
So for new agencies, I can help you with Medicaid compliance. I can help you get in compliance with contracts for new agencies to get into Medicaid waiver. I can help you get your applications get into DMAS portal. I try to stick with Virginia, but I'm willing to adventure out to new states. Anything that you need for new agencies, I'm willing to help teach you. And then for already formed agencies, I can help you Medicaid audit, get your documentation and compliance, and any questions you might have, I'm willing to help you learn.
Perfect. Well, let me end today by thanking you very much. I know that the ANCODA customers who have worked with you have really appreciated your counsel and your services. And I know you've given us some really good inputs, and we've worked really hard on making our state of Virginia documentation really easy for our folks to use and built into the system. And as I said, making sure that it all flows and that type of thing. Let me let me kind of go in a direction that we didn't say we were going to yet. But another thing that happens every time a home care visit is delivered in Virginia is that the caregiver electronically, usually on the mobile app, sometimes via telephony, is reporting everything that they do. So they're basically saying, yes, I performed these tasks, and they answer those questions about if there's a change in condition for that individual. And they do capture a client signature, they capture a caregiver signature, and various things like that. And as you've kind of figured out through this one, the state of Virginia calls all their documents DMAS, something or other. And then they, in this case, they create, they have to be able to create on demand something called the DMAS 90 for any one of these visits. And they might actually say, hey, give me your DMAS 90s for this week for this client, and they'll probably choose several clients and things like that. And we actually even built a feature into our software. They sometimes say, hey, I want to make sure you had a signature every single day. So put every day on its own sheet and things like that. So we're not trying to kill trees, but that we have had auditors have asked for that. So we've set that up so they could do it. And also, of course, they could turn that into a PDF and see it. But, so I guess that my question in all this is, for that daily documentation that they have to be able to produce for an audit on care, what are any special things or safeguards they should be, making sure that they are having covered in their, in this case, DMAS 90, or kind of their daily records of care as an agency?
So just remember, location. Always make sure to check to make sure your staff are clocking in at the house. You can always have your EVV put in where your staff are clocking in exactly at the location, or you can make it a requisite that they use the client's phone to be able to clock in for a more secure ability. And then other than that, best bet is to just do a random pop-up every once in a while, just for secured sakes. Other than that, I can tell you, Ken, I love your Encoda system for the sheer fact that you have the ability to do the DMAS 225s, and you have the ability to do all your DMAS documentation. So your system, I've seen, is a wonderful asset to being able to do home care. So thank you for what you do for us home care agencies.
Well, that's very flattering, and we really do appreciate it. Okay, well, now this time I said we were going to wrap up 3 or 4 minutes ago, but I think we'll do it really this time. And let me again thank Temperance Bruder for all you do for the industry and those Virginia agencies, and for educating all of our audience nationwide on how they can do a better job with their Medicaid documentation. So have a great day.
Thank you so much.
Thanks for joining us today on the Home Care Heroes podcast. Home Care Heroes is produced by Encoda, the software for the heroes of home care. You can listen to back episodes by visiting 4homecareheroes.com. That's the number 4, then the words homecareheroes.com.